I am Laura Boomer from the Children's Hospital of Richmond, and my co-moderator today is Laura Hollinger from the Medical University of South Carolina. This is a joint session between the Education Committee and the Surgical Critical Care Committee. I really wanted to start this session with a joke, but I couldn't come up with anything past two Lauras walked into a bar. Clicker, no, this one. We would like to acknowledge Alejandro Garcia, who was very integral into the creation of this session, but unfortunately was unable to be here at the meeting today. And I would just like to ask the rest of my panelists then to just quickly introduce themselves. Pramod.
Where we start?
Go ahead.
Perfect. I'm Laura Hollinger.
Pramod Puligandla, McGill University.
Scott Chicotka, California Cardiovascular and Thoracic.
I'm Julie Monteagudo. I did a pediatric ECMO fellowship at Columbia and finished my residency there, and did my pediatric surgery training at Brown and stayed on as faculty, and I direct the ECMO program there.
Adam Vogel from Texas Children's Hospital.
So the goal of our session today is to really discuss the variations in ECMO care, primarily involving cannulation, decision-making, and those strategies associated with the technical aspects, as opposed to the details of the critical care management. Turn the first case, we're going to have a lot of interaction. Please open your WUVA apps. There's polling during the app, and so I'm hoping that all of you will participate in the session. I'll turn over the first case to Laura.
Welcome, everyone. Thanks for being here this afternoon. I'm hopeful that our polling function will work in the app, so let's hope together. So I'm just going to get started with our first case presentation. So, to start off, we have a 4-kilogram term newborn, and there is refractory PPH, and the neonatologists have done everything. It looks like we're going on to ECMO. How would you cannulate this term infant for respiratory ECMO support? And if everyone will go into the WUVA app, open up the ECMO variations and care session, you should be able to answer the polling question through this link. Is it working for anyone? I see some head shaking. Well, we can always do a raise of hands. We can improvise here. So, we were going to have 4 different answers that might approximate your practice. This is a term infant who needs respiratory support, but we haven't had a dual lumen cannula available for quite some time. Who would go on open VA support for term infant? Raise your hands. Oh, it's still not working, okay. Who would do a PERC VV cannula with a dual lumen cannula, some of the ones that are currently on the market? All right, about half and half. And anyone doing any open VV with a dual lumen instead of PERC? Prefer open in a neonate? Yep. All right, and is anyone doing dual site in a neonate who needs respiratory support? Probably not. Okay, so it seems that most of us are split. We're either doing open VA or we're using some of the dual lumen vena-venous cannulas. I'd love to start off by asking our panelists some questions. Pramod, what would be your approach to this infant with respiratory failure?
So the access to a proper dual lumen cannula that we used to have, the Origin, really set us back. We had a lot of discomfort with using the Avalon in neonates, so that actually pushed us to doing open VA for the smaller infants, and perhaps reserving the Avalon for older and bigger child.
Did you have a weight cutoff or an age cutoff, or?
Generally, if they were over 6 kilos.
6 kilos.
Yeah.
All right. And Adam, did you do anything different in your practice?
Yeah, so I think in Texas Children's Hospital, before I'd gotten there, the approach had been using a dual lumen vena-venous cannula with the Origin or the Kendall when it was available. When that ceased to become, we had access to the Avalon, and so the group there was able to develop what was actually a pretty safe strategy using echo and chest x-ray to insert the Avalon cannula safely in patients that needed VV ECMO for isolated respiratory failure. And so that practice has remained current. We would certainly, I think, and I would certainly do it by open approach to ensure that all options were available at the time, just to make sure that always having VA ECMO, the option for it as a backup if needed. But our experience has been we can put the Avalon in safely in this patient population, and it's been very effective. I think we are very, very excited to have the right atrial cannulas now available that we're going to talk about a little bit, but I have yet to have the opportunity to use it, although I am super, super excited to try.
Very good. So we were going to go on to our next polling question. So let's presume we've all decided on a VV approach now. How has everyone been cannulating infants who needed VV? Is anyone in the audience using the Avalon cannula currently for infants? Raise of hands. Okay. And has anyone started using the new Crescent RA cannula? Okay, good amount of people here. So, Julia, I hear you have been using the Crescent RA in your practice. Do you have any tips or tricks for placement of these cannulas? Because I know there are a couple options.
Yeah. I think if you go to the next slide, we have some images to show, but we're really going to compare a little bit the Avalon, which was the only dual lumen cannula available for a few years when the Origin came off the market. And so that's an image of the Avalon on the right side of the slide. And so when the Origin came off the market, I called around to some other centers and asked what people are doing, and so many people went to VA, not wanting to use the Avalon because of the risk of right atrial perforation and the problems that come with trying to use a bicaval cannula in a small baby. It's very easy to have a malposition of the tip of the cannula into the hepatic vein rather than into the IVC. And so many people not feeling comfortable with that used VA ECMO. And so I had the opportunity, unfortunately there was one patient who was a good candidate for VV, and I did use the Avalon in that time between when the Origin came off the market and when the Crescent became available. But in September of 2021, the Crescent RA cannula came out, and this was a very exciting advancement. It's the only dual lumen cannula for infants that is FDA approved for long-term use. So even the Avalon only is approved for 6 to 8 hours, I believe. So it's nice to have that approval. And there are certainly a lot of design improvements that have been made to the cannula. As far as inserting it, I am still careful about the potential for injury during placement of the cannula. And so especially around the wire. I do this in the operating room under fluoroscopy. I have the luxury of having the operating room right next to the ICU. And so we pass a wire down, make sure it's going down into the IVC, and that we're not seeing any kinking or coiling of the wire. I think on the next slide I have some pictures of what that might look like. So the wire going into the right ventricle or coiling in the right ventricle, those are times where you have an increased risk of a right atrial perforation, and that's why I like to do it under fluoroscopy. But I know many people don't have the ability to travel to the operating room, and so as long as there's some continuous imaging, and many people will do that with an X-ray plate under the patient and taking serial X-rays, and many centers also use continuous echo guidance and watch under echo for the wire to go down into the IVC and not coil. I also like to use an echo at the end of placement to make sure that that arterial jet is pointed at the tricuspid valve. And that's another different feature of this new right atrial cannula that's different than the Origin, where the Origin had a punch side hole. This Crescent RA cannula has more of an angled jet, and so that allows you sometimes, the cannula can be a little higher. You don't have to insert it as deep as the Origin, where you may have more issues with right atrial perforation, if you have to insert the cannula deeper.
Very good. Well, we've created together a tip sheet for use of both Crescent and Avalon, and I just want to highlight this busy slide and tell you that it will be available for your use on the APSA toolkit. So I won't dwell too long on all the details that are listed here, because it will be available to you through both the APSA toolkit as well as social media. So we'll have that out. So for those of our colleagues that have been using this at first, it has some helpful tips and tricks. Anything in particular with insertion of the new Crescent RA that might be good to point out for those of us who are starting to use it?
Yeah, if you could go back a couple slides where the flow curves are. So when I place it percutaneously, I personally like to start with a micropuncture kit and exchange the wire for the 025 wire that comes in you can't go back? Okay. The 025 wire that comes in the dilator kit. There's a Biomedicus dilator kit that you can use with this. And what I wanted to show in the previous slide is that there are radio-opaque markers on this new Crescent RA cannula, and you want to make sure that the stacked dots are on the patient's right side. That kind of helps you to ensure that the arterial jet is correctly positioned towards the tricuspid. And then as far as the actual kit that the cannula is contained within, it has the obturator, which you use for an open placement. So there's a stylet that comes in that, and you have to take that stylet out, put the obturator in, and place the cannula if you're going to do an open or a hybrid cannulation. And then there's an introducer that accepts the wire if you're going to do a percutaneous cannulation. And the final dilator that you'll use, you'll dilate up to the size of the cannula that you're putting in, and that dilator is contained within the set. The other thing that's important in the kit that you get with the cannula is a special suture collar that you can attach yourself. And it's important to suture only in the recommended locations, which is also on a previous slide. And those locations are on that suture collar and at a gold reinforced ring that's also on the cannula. Right there is the image. And you can also suture and secure the cannula at the bifurcation. Places that are outside of those designated areas to suture the cannula, secure the cannula, can lead to the cannula fracturing. And so that's an important feature of placing it that I wanted to point out.
Yes, absolutely.
Upperman Vanderbilt. Dr. Monteagudo, I was madly taking notes, and I noted that you had at least 21 distinct steps. And I'm not making light of this, but when you think of it, depending on the size of the group, the question I had for you, are you the only one that cannulated Brown, or do you have a cannulation team? Because when we're thinking about a high fidelity system, you know, it's kind of tough at 2 o'clock in the morning to remember step number 17 and a half. So the question I have for you is, in your center, or would you promote that there would be a cannulation team so that you could have the best outcomes given the technical nature of what I just heard? Thank you.
Yeah, that is a great question, and I absolutely support the idea of a cannulation team. When we got these cannulas, we made sure that we in-serviced because the cannula is new, so we had the reps come out and go over all of these features with us, with the group of surgeons that perform cannulations. And in my role as the director of the ECMO program, I do assist my partners when they're using these cannulas for the first time, because I do want to make sure that we're doing this as safely as possible. And we also try to update our handbook so that it's available to anyone at any time, you know, in the middle of the night at different times like that. But I also do make myself available for that.
Hi, Jan Zelowitz, Memphis. So we've done the Crescent, I think, once, and kind of got in a fight with discussion with Dr. Pryor about whether we needed to actually have the wire in the IVC to put it in, because it's an RA cannula. And I never put the wire into the IVC with the origin. So I just was wondering why you needed to do that wire.
And we had that discussion a little bit last night too as we were preparing for our talk today, because the risk of right atrial perforation is less, but I know that with origin you could perforate the right atrium, and you know, I suppose a lot of the lines that we place, if you put the dilator introducer in too far, So I think it's just safer, and it's my practice to put the wire in the IVC every time.
Even for the right atrial placement?
Even for a right atrial placement, yes.
I think Katie had a question too.
Hey, yeah, Katie Russell from Salt Lake City. We've had this cannula for several months, and I'm just curious if other people in the audience have had the same experience. I think it's too short. You know, so specifically 2 cases, we had a large term neonate that we used that 13 French on, and we percutaneously stuck it, and it was up in the SVC, hubbed. And then I had a 1-year-old that I used that 15 French on, and the 15 French is only like a centimeter longer than that 13 French, and so we've had several instances in our early experience where these cannulas were too short.
Yeah, that's something else we were noticing and talking about as well. The 15 French is about 9 centimeters long, and we recently used a 15 French as well, and for a 6-kilo baby, and hubbed it. And our cardiologist was still telling us we're sort of at the SVC-RA junction. Now, I noticed that we didn't really have significant recirculation, despite the fact that the cannula was higher than I would have wanted it. And the patient, most importantly, the patient saturations were maintained. So I think that maybe the design of the arterial jet and how it's angled downward compensates a little bit for the fact that I think the cannula is short. And perhaps it was designed that way, but we've noticed that as well.
I think we have another question.
Melissa Danko, Vanderbilt. I was wondering, you know, we don't have the luxury of having fluorocompatible beds in our ICUs, and that's where we cannulate. I was wondering what the experience of the panel has been in terms of putting these in. We are using digital X-ray and live echo guidance, but I didn't know what other techniques other people were using.
That's an excellent segue. Adam, you want to?
No, we have the similar issues, I think, with the NICU beds, and we do all our cannulations in the NICU, and my practice has been very similar to what you're articulating, using real-time echo and digital X-rays, where you can obtain serial images in a short amount of time period to assess cannula position. I think is extremely safe, and so I think
I was not a plant either. Sorry.
I think part of one of the aspects of I think what we're going to continue to discuss through this session is, it's a session. There's a lot of variability in what we do and how we do it, and a lot of it is dictated by the resources that we have available at our institutions, because there's going to be so many differences across them. And so I think when we go back to basic principles, safety being the most important thing when talking about children, these kind of critically ill children, I think that's where that all comes back to. So I think there are several ways of doing things safely.
Okay, so what do we do if we need to go on VA? Let's say we perfectly place this new cannula or old cannula, but now neonatologist calls you 8 hours later and we've decompensated further. We need to go on VA. Maybe perhaps some of our panelists can take us through what they would do with that dual lumen cannula after it's already in when you need to convert.
So yeah, in this situation, I go for a hybrid cannulation, so I convert to VVA. And the way that I do that is, assuming that I've percutaneously cannulated for VV, then I do perform a cut down and dissect around the carotid, and invariably there's hematoma and it's an unpleasant experience, but once we have the carotid cannula in place, then I take a short segment of 1/4-inch tubing and connect that to a quarter Y connector, and flow with the oxygenated arterial blood to the arterial lumen of the dual lumen cannula and to the carotid. And because there's lower pressure in the venous system, you do have to put a partially occluding clamp on the arterial limb of the VV cannula, on the tubing that goes to that, and so that you can direct more of the flow to the carotid cannula to support the systemic circulation. And I put a flow probe on that tubing that goes to the carotid cannula so that I can monitor what that is and, obviously titrate to the patient's hemodynamics.
Okay, so on to our final question for this case. How do we all decannulate? Let's say we were on VA, we did this VAV situation, but now the baby's recovered, we're ready to liberate. How do we all decannulate from VA ECLS? Let's have another show of hands. Who would do an open cannula removal and ligation? Okay, that's the vast majority. How about reanastomosis after taking cannulas out? Okay. And does anyone have a special technique for putting a cannula in a neonate where you can withdraw it and do a simple repair of the arteriotomy or venotomy site? Okay, and then does anyone leave the cannulas and wait and be super sure you're ready to liberate before you finally decannulate? Leaving cannulas in situ, perhaps. Excellent. All right. So Adam, what is your practice when you're ready to decannulate an infant from VA?
I mean, we're definitely in the open cannula removal and ligating the carotid and the vein at this point, especially in this population. I think that's been shown over years and many studies to be, you know, safe and effective long term. And I know there's some, depending upon who you speak with, especially if you go talk to those in the congenital heart community and others, there is some debate about reconstructing the vessels. At least that has not gone into our pediatric surgical practice at this point, and I don't think we've seen any adverse sequelae from that.
And Pramod, I believe you perform reanastomosis in your practice.
So we were also a ligating center before, but with the arrival of a new pediatric cardiac surgeon, we've actually been able to develop a bit of a protocol, and really quite surprised at how good the tissue quality is, even if you've been for a few weeks on ECMO, that we're able to reconstruct, and we created a protocol. We've done about 3 or 4 neonates now, even with a very small posterior wall or bridge, being able to resect that, trim the edges, and then do an end-to-end. And so the information that we've been able to garner, we put them on low-dose heparin afterwards, and then we convert them to aspirin. We do ultrasound imaging within the first 24 to 48 hours afterwards, prior to discharge, and then serially after every 3 months. And I can say that the last 4 cases that we've done, that they've been patent.
Wonderful. And Julie, how do you decannulate?
So I like to wean the flows till we get to about 30 mLs per kilo per minute. And then I think on the next slide there's some pictures. I do like to build a bridge close to the cannulas so that we can do a test clamp and maybe for a prolonged period of time. I found this really useful recently. We thought we were ready to decannulate. I flush the cannulas forward with some heparinized saline, and then I allow the circuit to continue to circulate so that if the patient's not ready to come off ECMO, we can go back on. So this is an example of a VVA that there's a bridge that we've built in, and then on the next slide, just for VA. And so I find that a useful way to really make sure the patient's ready to come off. But I ligate the vessels as well.
Excellent. Yes.
From the chat, we have a comment from Alejandro Garcia. We have hung cannulas with heparin post-ECMO for some of our sickest CDH patients, for example, the fetal population, for a few hours before decannulating. So I don't know if there are other folks in the audience who are doing prolonged cutaways or bridges or recirculations.
Yeah, I think a couple other folks indicated that they leave them in situ, particularly maybe for higher risk patients or empirically, or yeah, high risk. Certainly.
I have a question for Julie also. Hi, Reichard from Nemours in Delaware. Hi. We had an interesting debate. We did a couple of VVA conversions, and we debated on how to wean. Because for VV you wean O2 and VA you wean flow. How do you do that? It was an interesting, about a 12-hour debate about that.
Yeah, that is interesting because you could, sort of wean the sweep, but I think while you're flowing to the carotid, I would wean it as a VA. And the other important point that I wanted to make about VVA is that there's a temptation to drain both the arterial and the venous lumen of the dual lumen cannula. And we know that when we try to do that, the arterial lumen will always clot. So if you're going to leave a dual lumen VV cannula in place and then add a carotid cannula, you should always continue to flow, antegrade arterial flow into the arterial lumen of the VV cannula.
Great. Well, I think we want to get on to our next case, but I have been told that now the polling questions are working on the Whova app. So if you want to go back and answer any of the questions, it might be interesting to see what percentages we all are for how we answer those. And we should be able to use that moving forward with the next case.
All right, Laura, thank you for leading that great discussion. We are going to now move on to an adolescent case. So sort of the other end of the spectrum. So you have a 15-year-old, 80-kilo patient who presents to the ER with a history of asthma and vaping-associated lung injury. He's intubated and admitted to the PICU, but has worsening oxygenation, is on maximal vent settings, and so the PICU calls you for ECMO cannulation. So now, for real this time, you should be able to open the polling. How would you cannulate this patient?
Apparently, we also earn points.
There's lots of answers coming in.
And while everyone's answering, we have another question from the chat referencing the last case. Have yet to see any evidence that repair is helpful or improves outcomes. Has something changed? Are we aware of any new data out there?
With respect to reconstruction? Yes. Right, so if you actually look critically at the evidence that informed the fact that there were equivalent outcomes, in fact, that evidence is actually pretty poor. And in fact, I do know of 2 large groups that are trying to look at reconstruction and look at neurodevelopmental outcomes for this population. So I think based on the evidence right now, I guess there's still some equipoise, but hopefully this will be figured out in the next 5 years once the trials are put in place.
So it looks like with almost 100 people so far, I think there's more than 100 people in here, almost 100 people answering, we have probably almost 60% are saying they would do a percutaneous VV with a dual lumen cannula. Obviously there's a lot of options here though, so Pramod, what would be your preferred method as far as location and your method of cannulation?
Right, so I think it all really depends on the status of the patient, and if you have a little bit of time, I think again with the arrival of our cardiac surgeon, we are much more neck friendly, and so we would actually try to cannulate the neck and then use the femoral access if we did not get enough drainage. And again, that's only because if for a longer run and rehabilitation, keeping cannula out of the groins may help facilitate the ability to rehab these patients. So.
Adam, what about you? Something different?
We would go percutaneous VV with the dual lumen cannula. I think it's isolated the respiratory failure. In many of these children, you do have some time to get all of the available resources present. We invested several years ago in a fluoro-compatible stretcher, which we keep next to our pumps in the PICU ICU environment. And so we were able to transfer the patients pretty expeditiously to that bed and bring fluoro into the ICU real time. So we'll use fluoro for the cannulation, and then we'll use echo to confirm the appropriate location of the jet, to kind of do the discount double check for the change in clinical status, which we'd expect after going on VV ECMO and seeing the appropriate rise in saturations and resolution of the shock state and things along those lines.
So Julie, I think you probably tend to use a different approach, yes?
Yeah, I like to do a 2-site single lumen percutaneous cannulation, so drainage from the femoral vein and reinfusing into the right IJ, and making sure that when you do that you have 10 centimeters of distance between the cannulas to avoid recirculation. And that's because I believe very strongly that if I'm going to place an Avalon, I want to do it in the operating room under fluoroscopy, and that's not always possible. And I think this is a safe way to get onto VV relatively quickly for an older child.
Scott, thank you again for joining us as our adult surgeon representative. Tell us a little bit about how you would manage a patient like this.
Yeah. So first of all, I don't belong. I'm an adult cardiac surgeon, but they invited me here because I did an ECMO fellowship in adult ECMO at Columbia, and I also helped to start and continue an ECMO program at UCSD, and I'm the director of the ECMO program where I am currently. And for this, we do a fair number of adolescents, which is why they let me up here. But so I would actually echo what Julie had said, is that typically in this scenario, you know, the patient is often pretty unstable. People are kind of getting a little bit anxious, and and moving them to the operating room, getting a lot of extra equipment, things like that can be very, very difficult. And even moving patients, I've found, to even another bed, you know, if the ventilator gets disconnected or something, can be catastrophic. So the dual site single lumen cannulation is a good, safe way to get on ECMO, and it gives you a lot of options for additional flow or whatever you need. Yeah.
So this is we had a limit of 5 questions, but we have lots of questions. So this is a raise your hand question. So we're just gonna jump that this kid did great, is ready for decannulation, and so I wanna know what everyone's management of the vein would be. Again, interestingly, since over 50% said percutaneous dual lumen, I'm interested to see how many of you would just pull the cannula and hold pressure? A lot. How many people would repair the vessel? And how many people would ligate the vessel, open ligation? What about our panel? Adam?
Pull and hold pressure. Really nice, generous O proline or O silk figure of 8 suture right on top of it. Really nice, quick, rapid pull, tying that down, and find someone that's willing to hang out and hold pressure for about 15-20 minutes, and should do the trick. Key part is really keep getting that, I think, suture in place and making sure that that's there, I think, is incredibly valuable.
Julie or Pramod, anything different?
No, similarly, I would pull and hold pressure.
Yeah, as I said, I think our practice change has been to attempt reconstruction.
So we're going to go back to the initial scenario. I know in the first case we talked about conversion to a VVA type scenario. We're just going to say this patient now this time hasn't gotten to ECMO yet, initially did well on the ventilator, but eventually developed some signs of sepsis requiring multiple vasopressors. And this time, in addition to that worsening respiratory failure, he's got biventricular heart failure evident on echo, and the decision's made to proceed with echo. So back to the polling app. This time, how would you cannulate the patient given these findings? So as the answers are coming in, Julie, tell me how you would approach cannulation in this situation.
I would do a percutaneous femoral cannulation. And if there was any advance notice that this patient's getting sicker and we're thinking about ECMO, it's always nice to try to put lines in advance. Because sometimes once you're on pressors and there's a lot of vasoconstriction, it can be difficult to get those. But I typically will do a percutaneous approach and exchange over a wire if those catheters are already in place.
Adam, what about you?
So I think that the key element in this is the transition into sepsis and septic shock. And so, at least for me, I think a lot of folks, what we've learned over the past several years, probably the last 10 years or so, initially from some single center retrospective studies, but now some fairly reasonably decent multi-center retrospective studies, is that these kids do better and their survival is better when you can get to higher flow rates. And these children often receive and do better with suprasystemic flow rates in the upwards of 150 mils per kilo per minute, 160 plus. And we have found it very challenging to be able to achieve those flow rates through percutaneous or open peripheral cannulation approaches. And so the answer to your question, by way of that maybe meandering introduction, is we would favor a VA central cannulation strategy. Now that is predicated on the child being stable, air quotes, stable enough to be able to transition to the cardiac IC, to the cardiac ORs for that cannulation. If the child wasn't stable enough to do that, we would do percutaneous VA ECMO at the bedside, get them settled from a hemodynamic standpoint, and then convert them to central cannulation. Our approach in the at the bedside would be image-guided by ultrasound, percutaneous, typically starting with putting a wire down the SFA for a antegrade cannula, and then proceeding with putting the arterial cannula going up through the femoral artery, again percutaneously. We would typically go with venous access. I think there's one or two ways, and a little bit depends on whether they're a central cannulation strategy appropriate. So for instance, if after we have the discussion with our cardiac surgeons, they're not a candidate for central cannulation, so redo sternotomy, sometimes significantly immunocompromised patients along those lines, they won't be a central cannula appropriate for a central cannulation strategy, and then we know we're going to have to stick with the peripheral strategy more, and that's what we're going to have to go with. We will go ahead at the time we're doing the groin cannulation with the antegrade distal perfusion cannula for the arterial access. We'll go ahead and drop an Avalon cannula through the right neck for both the venous drainage and also for reinfusion to minimize the risk of north-south syndrome if we expect this is going to be a longer run. Another benefit of having an Avalon or a dual lumen in the neck is that if at least particularly in this case, if the sepsis resolves and we no longer need the arterial support, we can decannulate the arterial line, but the lungs may not have yet recovered, and we can still have the benefit of having the cannula in place to provide respiratory support. And so it's sort of how we do things right for the moment, but also thinking about where things might go with the clinical trajectory of the patient.
So Adam, that's an interesting point that you bring up. Can you explain what north-south syndrome is to the group?
Yeah, north-south syndrome or Harlequin syndrome, it's when you have a groin cannulation and you're able to reinfuse oxygenated arterial blood to the distal aorta, but that oxygenated blood doesn't quite make its way up to things like the heart or the head or the arms. And so clinically what you see is kind of bluish on the head, upper chest, and then kind of pink and everything from the abdomen down below. And so I think we'd all agree it's probably pretty important for oxygenated blood to go to the heart and the brain and everything in that part up there. And so by putting in some sort of option to provide oxygenated blood back into the right heart, so then that it goes through the normal cardiac physiology and gets ejected into the aortic arch, you can provide oxygenated blood, although, again, depending upon the physiology and the characteristics of the cardiac function, at least some blood, oxygenated blood to the heart and brain.
So in the poll, while these lovely panelists have been talking, 40 out of 92 said VA in the neck, which none of my panelists said. A rule? Are you out there? Are you hiding from me? Do you want to talk about VA cannulation in the neck? Or Mark? I got some critical care plants in the audience.
Yeah, I'm the plant. So with regards to the site, the approach that I like is either it fits in the leg or it doesn't. And so we would screen with ultrasound to measure the vessel, and you can get a little bit with Pavarin and things like that, but you can't bank on it. And so we'd measure, and if they're appropriate, we could do a femoral, but otherwise they're getting one in the neck. And yeah, they can get Harlequin syndrome, and you can add an extravenous cannula up to reinfuse some oxygenated blood. But and then since I already put the question in the chat, I was going to ask for the people that are doing perc arterial stuff, because I've never done that. Do you have any experience with using the percutaneous closure devices for the repair? Because one of the big drawbacks is that we have to have vascular or somebody come and reconstruct, because we leave distal perfusion cannulas in everyone.
That's a great question, and we're going to get to that in a minute.
Okay.
and we'll answer your question. Arul?
So, I'm Arul Thermorthy from Michigan. We also, for the teenagers who need VA, the larger kids, we've been doing just neck cut downs. It's comfortable. You know how to do it. From the younger kids, had good outcomes. Overall, the data's backed that up. Not seeing any, at least immediate issues. People worry about stroke in these kids, but it's usually because you're usually in an ECPR situation anyway. It's going to be sequelae from when they went down in the first place. So getting them on quickly in a way that we can do in the ER, in the OR, or in the PICU has just kind of been very comfortable for us. And it's a big, nice dissection. The only comment I'll make is just make sure you have Army and Navies for your retractors. Just it's a little bit bigger than you're used in the little kids. So I just go to a bigger retractor right off the bat.
That's great. Scott, tell me how you would manage this patient, particularly if this is you feel like you have a little bit of time versus if it's pretty urgent.
Yeah, so we would do something slightly different. And again, time is kind of the big factor, percutaneous in an emergency, but typically it would be a femoral cut down onto VA ECMO, but we would use, we'd sew a graft onto the artery. The graft allows you to be able to kind of keep the cannula more outside the artery, allow distal perfusion, so you don't need an antegrade or distal perfusion cannula. And it also makes closure much, much easier. We've ambulated people on this, adolescents on this. It's pretty safe from our experience.
And then Julie and Scott, if you can discuss a little bit more for the group, your methods that you use for placement of a distal reperfusion cannula.
At our institution, we're fortunate to have vascular surgery assist us with the placement of the distal perfusion catheter. So as mentioned before, it is helpful to get the wire into the SFA prior to putting your cannula in while you still have good flow there. So that's usually what we'll start with. And then once we're getting ready to decannulate, it's helpful to have vascular surgery already involved with the reconstruction of the artery.
Yeah, for us as well, the distal perfusion cannula, it's always very nice to have a wire in, but sometimes you don't have that luxury. And at my institution, I'm it. So I'm the person that's sitting there trying to figure out how to get the distal perfusion cannula in after we've already gone on, and it can be difficult access. And in some instances, I've actually had to cut down and find the SFA. And, yeah, so it's essentially the same as what you would do.
Another thing I like to think about, even though I'll place the distal perfusion catheter for every femoral arterial cannulation, is that there's still a high risk of limb ischemia, and I try to limit the size of the arterial cannula that I put in, so I don't like to put in a cannula bigger than, usually a 15 is what I'd like to use, but a 17 at the most.
Yeah, I would actually echo that. I would say for almost every single adult, and probably every adult in this room, a 15 cannula is the biggest you would need. It's mainly just offloading of the ventricles to be able to give you enough support to get through. And again, yes, everyone gets a distal perfusion cannula. Everyone.
From the chat, we have a couple of questions relating to the graft onto the femoral vessels. Can you talk a little bit about what material you use? Do you tunnel the graft, kind of the technical aspects of the chimney?
Yeah, so I would use a HemoShield graft. Depending on it depends on the cannula size. You want essentially just above the size of what cannula you're planning on using. So a 6, 8, or 10 millimeter graft. Again, a 10 millimeter graft is a really big graft, and a 15 cannula is way too small for that. So bevel the graft, and then insert the cannula. I don't insert the cannula all the way into the vessel. I just leave it in the graft, sew it on with some heavy silks, and then attach the cannula to the leg. It's really helpful, especially for closure. You don't have to go do after a percutaneous femoral cannulation. I would always take a cannula out and close it, whether it's a patch repair or whatever. But with the graft, I usually just staple over the graft. And
Juan Gurria from Cincinnati. It's actually a follow-up question for that. We've seen gotten some challenges from the graft. Any tips on avoiding overcirculation on the leg that ends up requiring fasciotomies or even ischemia from the pressure?
Yeah, so one of the big things for me is beveling the graft. I usually put a 60-degree bevel on it, so it's a pretty sharp bevel. it makes the anastomosis of the graft a little bit more challenging, but I think that allows the flow to go a little bit more retrograde more easily. And then I do always check afterwards to make sure that we do have enough flow going retrograde, and sometimes we'll leave whether it's just either some sort of distal occlusion device or partial occlusion device on the remaining femoral vessel that's like umbilical tape or something if that's necessary, and then leave the leg somewhat open, like with staples.
Okay, our last polling question. So now this patient has improved. This is the question for Mark Ryan. And Sona's now ready for decannulation. How are you going to manage this patient? So this may be the most interesting polling response yet. Again, confirming the variation, because we're almost completely split between the 4 answers. So panel, tell me, are you all repairing the vessels? Pramod?
Yeah, we would open. We usually use an open technique or a hybrid technique for cannulation, and then we would decannulate and repair.
Scott, why don't you talk to us a little bit about your methods for repair?
Yeah, so if it's a percutaneous cannulation, I would decannulate in a standard fashion, but then for closure of the vessel, it just depends on how much vessel is essentially damaged. For the most part, I pretty uniformly just will patch the vessel closed. I find that using a purse string or doing just a direct repair interrupted sutures can sometimes limit the flow distally. So I just hate being in a situation like that, so it's just so much nicer to just, get good control and then close it with a patch.
Anyone else?
Yeah, it's interesting because our practice has evolved a little bit over time. So as we started the percutaneous cannulation strategy, we were able to develop collaborative relationships with our interventional radiology colleagues, and what we found is that we were initially in the pull and hold pressure category, even for the larger arterial cannulas, the 15, sometimes even the 17s. And what we would do is when we would remove the reperfusion cannula, they would do it under ultrasound guidance, and there are commercially available products that they were able to inject around the SFA at the time to kind of close that site. So again, kind of leading a little bit to the question about closure techniques and different aspects that are there. And then we would pull the cannula and hold pressure and utilize the FemStop device and things along those lines so we could continue to assess it. And we had really good success with that. I think we wound up doing, I want to say, about 7 patients, and no one required a trip to the operating room for bleeding or things along those lines. And then we had an experience where one of the patients, so percutaneous cannulation, image guided, but doing a surveillance ultrasound with a concern for clot, we recognized that the cannula was actually above the insertion site was above the inguinal ligament. And so the concept of pulling that cannula and holding pressure and the risk of retroperitoneal hematoma was just too high. And so we subsequently developed a collaboration with our vascular surgical colleagues to take that child to the OR and do a cut down and removal and complete vascular reconstruction, typically with a patch. And since that relationship actually wound up being really nice, that's kind of what our practice has evolved to now. And so we've been able to we have two of our adult vascular surgeons that we will get involved at the point of decannulation for facilitating the vascular reconstruction.
Now there's a decent number in the polling that said that they would ligate the vessels. Anyone want to speak to that? Laura?
Well, I think I'm going to presume that the folks like me who would consider vessel ligations were referring to neck cannulation, even in an adolescent or teenager, which it really kind of depends on how long you're on, right? I have certainly performed repair in conjunction with our cardiac colleagues in patients with very short runs who had excellent vessel integrity afterwards. However, when we've had very long support runs with a combination of support, VA, VAV, back to VV, whatever it is, and you have a wound that's been open for weeks, reconstruction is simply just not possible due to tissue integrity. So I've certainly done plenty of neck cannulations in older children who have crashed on and stayed on for a long time. And I've also, not had any problems with that.
Dr. Eubanks.
Hey, Eubanks, Memphis, Tennessee. A comment, and I guess maybe a point for discussion. I think that's important as a specialty that pediatric surgeons maintain the skill set to do all the things we're talking about. And a lot of times what happens in certain institutions is you have one really good interventionalist or one really good vascular surgeon, and you rely on them, and then they leave. And then so all of a sudden, no one feels comfortable doing all the things you've just described. So I would just, my charge for pediatric surgery as a practice is that we should take ownership of this. I've seen a couple of times at our institution where you have 4 different services, surgical or interventional services, consulted to put one patient on, and then they get them all successfully. You've got cardiac surgery, you've got cardiac interventionalists who did a part, you've got us who had to come in and bail them out, you've got vascular surgeon who then has to come in and reconstruct, and then somebody's got to do a fasciotomy. So, and then what happens is nobody is the leader. Everyone says, well, my part's done, my part's done, my part's done. And the ICU a lot of times just kind of gets left holding the bag, and as does the family and the patient. So I'm just going to make my soapbox plea that as pediatric surgeons, this should be our territory. And I'm not saying we don't collaborate to get the best team at each institution, but I just think that's critical, and I'd be interested to hear any comments on that.
I completely agree. I think for these children, these critically ill kids on VA ECMO, I think that is squarely in our wheelhouse, and we are the directors of that ship. And maintaining that level of competence and the skill set, I think, is really important. And because at the end of the day, when you're talking about these collaborative services, and it's great to have those relationships, sometimes they're not available, and we still have to take care of the children. So I would 100% agree with your comment, Dr. Eubanks.
I agree as well. And when we do have other services involved, I scrub in with them and I participate in the procedure. But I also strongly agree with what you said, that we need to maintain our leadership and responsibility for the care of these patients. That's something I personally believe in as well.
Yeah, I think this is going to be unanimous for that. Yes, it's important for us, and I personally will scrub with my cardiac surgeon when we're reconstructing or doing stuff. And I think it's that teamwork that helps. And you're right. It's a precious resource, and if that precious resource is not there anymore, then you have to go back and start rethinking things. So I completely agree with the sentiment.
All right, we have. Oh. Jan Sol. No, it's okay. You go. Jan Solitz can wait.
Former fellow.
Hi, Leo Malvezzi from Miami. I'd just like to hear if anybody feels the same way. I've been arguing with the administration for a few years that we need a fluoro bed in the ICU. There's no reason for not having a fluoro bed in the ICU. It's better to see where your wire is. The fact that everybody can stand on one leg, do things with one hand tied behind their backs at 1 o'clock in the morning is not an excuse for doing things poorly. And I would ask that we say that we need fluoro beds. Like, all of us say that we need fluoro beds. That way, when they say no to me, I can say, well, look, APSA says we need fluoro beds. Please say we need fluoro beds.
Okay, we've had a number of complications with limb ischemia recently, it's really been horrible. And then we've had a interventional cardiologist place percutaneous, arterial access for ECMO, and then failed to get a reperfusion cannula in. Do you have any sort of backup options for how to do that, like the posterior tibial approach? And they were talking about a contralateral reperfusion cannula. Or, I don't know how that would work, so I just was wondering if you had any tricks.
I don't know about the contralateral one. I don't think I've seen that one, but either a percutaneous or cut down on the PT and a retrograde going up, I think is well described and would absolutely be my bailout if I couldn't get something antegrade down the SFA.
Yeah, I would agree, Tim. Go PT.
Dr. Herschel.
Ron Herschel, Ann Arbor. So I've been doing ECMO for 35 years in adults and children, and I think it was Jay Zwischenberger who liked to say that the potential complications in ECMO are only limited by your imagination. And I would, I stood up at this meeting and said exactly what the gentleman previously said, and that is, I would not be putting wires in unless you are using fluoro. I can understand doing intermittent imaging. I get that. But we actually transport our patients, not necessarily the neonates, because, well, if you're going to be using a right atrial cannula, I don't think you necessarily need to use a wire, and I don't necessarily think you need to use fluoro. But if you're going to be putting an Avalon cannula in, and even, two-site VV, I have the unfortunate events of having had wires in two-site VV be in adults now, be in the wrong place, and with catastrophic consequences. And so I think, one of Marcus Jarboe, who's trained in both IR as well as pediatric surgery, has said that interventional radiologists would never be doing what we're doing without imaging. So, I agree. I just think we should not be doing, playing with wires, if you will, and guessing where they are. But we're talking about very complicated cannulations here. And at Michigan, we have 13 pediatric surgeons. I think I was talking to Bob Schamberger last night, 24 at Boston. Everybody can't be doing cannulations, but yet we have an issue if we break out the ECMO call. So I'd love to hear what the panelists, this was brought up early in the session, but I'd love to hear what the panelists think about it, the solutions, how do we keep everybody competent? If you're doing, 10, 12, 15 pediatric, not neonatal now, neonates are even fewer, but pediatric cannulations a year, and you have X number of pediatric surgeons, how do you maintain your competency? Do you limit the number of surgeons that are cannulating? And again, then if you do limit it, then you start getting into the call issue.
Everyone's looking at me to start, so okay. That's a really, really, really hard question. To be honest, I don't think I know that answer. I think it starts with safety and level of comfort, and I think, I am very privileged, I think many of us are, to practice in practices where we trust our partners, and we are there to support our partners. And that's particularly, I think, important in these complex kids. And so, when we talk about call schedules and things along those lines, and I feel like it's almost a little third rail of something as part of this conversation, but I think we have learned that complex, what's the right way of saying it? Variability with complexity can be a recipe for disaster, and that there is anything that we can do to standardize approaches, and particularly we're thinking about standardizing approaches within institutions, because there'll be so much variability across institutions, but standardizing approaches within your institution and ensuring that the support's available at whatever time or whatever day, if it's needed. I think that's where you start, and then I think there's certainly a role for simulations that are part of this process, and there are some incredibly high-fidelity ECMO simulating mannequins and programs that are out there can also be part of it, but that's a whole other, I think, line of discussion. But I think collaboration and trust and preparation and standardizing as best we can is where to start, and then I'll let someone else take it from there.
Yeah, I think I can offer a few points to that as well. I work in a practice of 5. We all cannulate for ECMO, and we all back each other up at the same time because we have had simple things and much more complex things. And I think it's been important in our practice for myself, from a surgical perspective, to remain very involved with all ECMO patients. I tried around on every ECMO patient who is on at least intermittently and remain engaged. I'm the medical director of the ECMO program for all 3 of the ICUs. We have a monthly case review similar to morbidity and mortality, and we invite the whole multi-D group. And I think having a surgical presence and leadership to that program is incredibly helpful, and it's also helpful in disseminating information. So when we first got the Crescent, I was able to review it with the rep, review it with other surgeons who had placed it. I provided an educational handout. I went to all my partners. I had all the equipment, and we simulated it before we put the first one in, and that was actually like the very next day. So it's important, again, for surgeons to remain on a leadership forefront of hospitals who have ECMO programs. I think that's how we stay up to date.
I think we are officially out of time. And as my committee knows, I like to try to start on time and end on time always. So we're going to end it here. Obviously, all the panel is available if you all have other questions during the rest of the meeting. Any of us would be happy to talk. I want to thank the program committee and the PDC for supporting this session today. And I would like to thank all of my panelists, my co-moderator, and the members of both the Education Committee and the Surgical Critical Care Committee for helping us today. And I think the important lesson here, as Adam mentioned earlier, is really that the most important thing is there's significant variability even amongst our most experts here. And so most importantly, everyone should do what's best for the individual patient and based on their comfort levels and resources available. Thank you again for attending our session.